How's it going, guys? We have a pass level question for Cardiopulm for step one. Could even argue internal medicine 2CK. So no excuses, hyper basic, hyper pass level. 61-year-old man. He's got a 6-month history, shortness of breath on exertion, takes no medications, blood pressure 140/90, BMI 35. S3 is auscultated on a cardiac examination. S3 means you have a dilated left ventricle. Okay, so it's from increased preload. Almost always pathologic. Okay, usually means dilated cardiomyopathy. Rarely, okay, it can be seen in pregnancy due to the increased preload, sometimes high endurance athletes, but 99% of the time it means you have a dilated left ventricle. S4, in contrast, means you have a stiff left ventricle, which would be from afterload. Okay, so hypertrophic cardiomyopathy, restrictive cardiomyopathy. So S3 is preload, S4 is afterload. In contrast to S3, S4 is always pathologic. So it's a long discussion, but let's just keep moving forward. So ECG shows left axis deviation. You say, no fucking idea what that means. This just means left ventricular hypertrophy. Okay, so this is just the strength of the electrical conduction in the heart when you look at an ECG. You don't need to be able to identify this on USMLE. Just when you get a vignette, if they say left axis deviation, if they say paradoxical splitting of S2, if they say a left bundle branch block, those all mean left ventricular hypertrophy. You don't need to worry about mechanisms or anything like that. Just left axis deviation, paradoxical splitting of S2, left bundle branch block, all left ventricular hypertrophy. In contrast, if we had right axis deviation, if we had wide splitting of S2, if we have a right bundle branch block, those all mean right ventricular hypertrophy. Question wants to know which following most likely explanation for patient symptoms here. So look at the answer choices. As I said, it's pass level. It's not going to be a lengthy clip here. So we have presumably a guy who, because on a background of hypertension, obesity, risk factors for dilated cardiomyopathy, as I just preached with the S3, okay, and the left ventricular hypertrophy at the left axis deviation. So he's got left heart failure at a minimum. There's no evidence of right heart failure here. So there's no JVD, there's no peripheral edema, but he's got pulmonary findings. This is left heart decompensation. So we say, well, what's the mechanism for the dyspnea here? And so you're going to have increased left atrial pressure because you have the left ventricle is not working properly. So as we have the S3, this means systolic dysfunction. It's dilated, so it's not contracting the way it's supposed to. So the left ventricle is not working like it's supposed to. So that's going to back up to the left atrium. Well, left atrial pressure equals pulmonary capillary wedge pressure. All right. So LAP, that's going to back up to the pulmonary venules, pulmonary capillaries. A backup pressure is a fluid pressure. That's hydrostatic pressure. So we're going to have transitation of that fluid into the alveolar spaces. Transitation just means it's compared to serum, it's relatively low in protein and low in LDH. Okay. So, and it's due to non-inflammatory conditions, such as just a backup pressure, hydrostatic pressure. So our answer here is increased hydrostatic pressure. You can see the answer on the USMLE sometimes, increased pulmonary capillary hydrostatic pressure. It's not difficult, okay? But you say, well, what about increased vascular permeability? Because that is a sort of a buzzy distractor, okay? Well, as I just talked about, this would be more for inflammation, okay? I talked about transitation with how that's non-inflammatory, but in contrast, vascular permeability, this would be for exudate. This could be ARDS, for example. Could even be pulmonary embolism or cancers. So ARDS, increased vascular permeability, increased spacing between endothelial cells, usually due to TNF alpha. Okay, in sepsis, for example, when you have low blood pressure, dilation of peripheral arterioles, and leakage of the vasculature, that's due to TNF alpha. So in an inflammatory scenario, widening of the spacing between endothelial cells, increased vascular permeability. In this case, it's not what we have, okay? And you'd have a relatively increased LDH and protein compared to your serum. 2CK stuff, all right? Obviously, there's criteria for that, where if you have a pleural effusion and LDH of the pleural fluid is greater than 0.6 compared to serum, or protein greater than 0.5, the ratio, that's going to be exudate. Okay, I know a lot of you guys studying for step one. So your short point of consolidation here, pass level, as I said, is that when you have left heart decompensation, left heart failure, and you have a backup of fluid into the lungs, the dyspnea, this is due to increased pulmonary capillary hydrostatic pressure. I just talked about point of consolidation, didn't fucking mention that decreased oncotic pressure, even though wrong fucking answer in this case, you need to know that This would be the answer, presumably, if you had peripheral edema, if you had even dyspnea in the setting of nephrotic syndrome or liver failure. Okay, nephrotic syndrome, you're losing protein in the urine, and in liver failure, you're not synthesizing albumin. So patients who have extravasation of fluid in the interstitial spaces, that's going to be to decrease protein pressure. Oncotic is a retention pressure. It's a solute pressure. It retains fluid within vessels. So if you have decreased protein in the intravascular space, you're not going to be able to retain fluid as easily, and you get extravasation. Okay, so this is choice B is for nephrotic syndrome and hepatic insufficiency, but we have our correct answer, increased hydrostatic pressure, which is cardiac. You know the deal. To make more content, if you like my stuff, subscribe to my channel. Appreciate your time. That's it.